Hi all, welcome to Raaonline. Today we are going to deal with one important topic in thoracic surgery, that is the post-operative management. Here two things are very important. How the patient is going to recover after surgery. Next is what are the various complications you are going to deal in the post-operative period. These are the two main headings of this topic. Now coming to the recovery after thoracic surgery. It is called as HERAS, enhanced recovery. You make the recovery faster. The first common thing which is required for this enhanced recovery is the multi-specialty approach to the perioperative management. What do you mean by multi-specialty? You involve the anesthesiologist, surgeon, and pulmonologist, oncologist, intensive care specialist, chest physician, nutritionist, whatever is important in the enhanced recovery of the patient should be involved. So it is going to be a multidisciplinary approach. And now all surgical specialties have adapted enhanced recovery for the respective surgery. The most important principle in this enhanced recovery is to reduce the stress response to surgery. Thereby, when you reduce the stress, your recovery is faster and thereby the outcome is better. By doing enhanced recovery, you reduce the complication, reduce the length of hospital as well as ICU stay, and very importantly, the cost of the patient comes down drastically. Coming to the surgically modifiable factor for enhanced recovery. What is the evidence level and what is the recommendation grade for each factor? The first and foremost is nutritional supplement if patient is malnourished. Here the evidence level is moderate and the recommendation is really strong. Next, coming to the smoking cessation. You reduce smoking. Here the evidence level is high, the recommendation is really strong. Coming to venous thromboembolism prophylaxis, mechanical as well as pharmacological protection against venous thromboembolism. Here the evidence level is moderate, again the recommendation is really strong. Antibiotic prophylaxis, evidence level is high, recommendation is strong. And coming to minimally invasive surgery like video assisted thoracoscopy, that too in early lung cancer. The evidence level is high, the recommendation is strong. And coming to post-operative incentive spirometry, the evidence level may be low but the recommendation is really strong. So these are the various recommendations: nutrition supplement, smoking cessation, prophylaxis against venous thromboembolism, antibiotic prophylaxis, minimally invasive surgery, and post-operative incentive spirometry. Now coming to anesthetic modifiable factor. First is isolation of the lung either by double lumen tube or single lumen tube. Thereby you prevent the contamination and the surgeon can do the surgery freely. Here the evidence level is moderate, the recommendation is really strong. Coming to lung protective ventilation, okay, low tidal volume and a minimal PEEP, that is lung protective ventilation. Here the evidence level is moderate, recommendation is strong. Coming to temperature monitoring and active rewarming, this is evidence level is very high and the recommendation is very strong. In thoracic surgery there is always a chance of hypothermia. You are exposed to the atmosphere, so and these are all prolonged surgery, so there are chances of hypothermia. So you should avoid the hypothermia. So you should monitor the temperature as well as actively rewarm the patient. Coming to analgesia, combined regional and general anesthesia. The evidence level may be low but the recommendation is really strong. We all know that what are the benefits of analgesia. If you give regional anesthesia, definitely the outcome is going to be far better. Multimodal management of post-operative nausea vomiting. The evidence level is moderate but the recommendation is strong. And coming to inclusion of acetaminophen and NSAID in analgesia. The evidence level is high and the recommendation is really strong. And another important thing as an anesthesiologist, you can play a great role is the fluid management. Here, it is not even euvolumic, it is restrictive fluid management in thoracic surgery. Here, the evidence is high and the recommendation is really strong. And the last factor is non-intubated thoracic surgery. Here, you give thoracic surgery without intubation and patient being on spontaneous ventilation. Here, the level of evidence is low and it is not recommended. So, summarizing the anesthetic factor again, lung isolation, lung protection, active temperature management, good amount of regional anesthesia for pain relief, avoiding postoperative nausea, vomiting, and addition of NSAID to your regular analgesic management and euvolumic fluid management. So, to summarize the eras, that is enhanced recovery after surgery, in the preoperative period, do a nice patient education and counseling, optimize the patient nicely. For example, the smoking cessation has to be continued for 2 or 3 weeks, wait for 2-3 weeks and give nice chest physiotherapy, expand the lung nicely and then go for surgery. So, optimize the patient. If the patient is having some end organ damage or some other organ damage, you try to optimize. For example, a coronary artery disease is there, patient is in failure. You try to optimize that particular disease and take the patient for thoracic surgery. Risk assessment, assess the risk of the patient and place the patient according to that risk and go for enhanced recovery. Smoking cessation, try to reduce the fasting period to as minimum as possible. Then comes the antibiotic prophylaxis as well as thromboprophylaxis. In the intraoperative period, go for minimally invasive approach, short acting anesthetic, protective lung ventilation, avoidance of fluid overload and presence of thoracic epidural analgesia. In the postoperative phase, the pain relief should be really good. Go for early ambulation. Start early oral nutrition as soon as possible. Chest drain removal should be done as soon as possible. Avoidance of fluid overload in the postoperative period and start the physical therapy as soon as possible. So, these are all the various factors which can be done to improve the enhanced recovery after surgery. Now, coming to the second part, what are the complications you face in thoracic surgery? Few early complication includes prolonged air leak. For example, a bulla or a bleb, you can have air leak. Pulmonary edema, this can be in the postoperative period. It can be negative pressure pulmonary edema or reperfusion pulmonary edema or your fluid management. You might have given a lot of volume and there is high capillary hydrostatic pressure and patient might develop pulmonary edema, or the patient can have acute respiratory failure, acute lung injury or acute respiratory distress syndrome. Here, your positive pressure ventilation and lung protection strategy plays a major role in avoiding this complication. Infection complications like pneumonia or empyema. The patient might develop hemorrhage, hemothorax or chylothorax. Another important early complication which affects the morbidity and mortality in thoracic surgery is the fistula. It can be bronchopleural fistula or esophageal fistula. Your lobar tension, cardiac herniation, particularly when you do a pneumonectomy, deep vein thrombosis and pulmonary embolism, and not to forget the cardiac complication of thoracic surgery, arrhythmias and myocardial infarction. These are all early complications following thoracic surgery. But coming to some major complication which can really affect the outcome of the patient. The potential major complication includes torsion of the remaining lobe after lobectomy. For example, you remove the left lower lobe. What happens to the upper lobe? The upper lobe gets torsion. So, this is going to affect the outcome of the patient. Dehiscence of the bronchial stump, particularly when you do a pneumonectomy. Hemorrhage from the blood vessel around the thoracic cavity. These are all the early major complications. But fortunately, these are all infrequent. Other two major complications includes respiratory failure and cardiac herniation. Respiratory failure is the commonest cause of major morbidity following thoracic surgery. This respiratory failure develops when there is inadequate respiratory preserve in the preoperative period. Cardiac herniation, although it is very rare, it is fatal if not quickly diagnosed and appropriately treated. Now coming to the torsion of the remaining lobe after lobectomy. Here you can see the left upper lobe and the left lower lobe. The left lower lobe is being removed due to the disease of the lung. Here you remove the left lower lobe and you can see there is a 180-degree torsion of the left upper lobe. Our left upper lobe is coming as a clockwise rotation and it is coming into the space which is created empty by the removal of the left lower lobe. And because of this, there can be enlargement due to venous congestion, and finally the left upper lobe adjusts to that position. Now coming to the left lower lobectomy, the left lower lobe is being removed and here you can see the left upper lobe is remaining. Then it undergoes a torsion. Here you can see a clockwise rotation of around 180 degrees and the left upper lobe is in a different position. What has happened after lobectomy? Now coming to dehiscence, here you remove the entire left lung. This left lung is totally diseased and at the bronchus you cut open and you do a pneumonectomy. What happened to this bronchial edge? Normally this bronchial edge, if you suture properly, it undergoes angiogenesis and it is secured properly. Here you can see it undergoes tissue formation and it is sealed. But sometimes what happens is there can be a dehiscence of this stump. Okay, it may not be sutured properly, or if you give positive pressure ventilation, the air might come through it. So there can be dehiscence and fistula can happen and this can lead to dangerous hypoxia and you may not be able to maintain the ventilation. That is very important. Dehiscence of bronchial stump is a very dangerous complication following pneumonectomy. Now coming to the third major complication, which is hemorrhage from major vessel. Thoracic cavity has lot of vascular structure, be it artery, vein or pulmonary circulation. Lot of vessels are involved. So even if one major vessel is involved, it can lead to a major hemorrhage. Coming to the systemic artery, it can be common carotid or subclavian artery. This is subclavian artery and this is the carotid artery. You might injure the carotid or subclavian artery. These are all systemic artery. Coming to the venous system, you might involve the subclavian vein or the superior vena cava, which is formed by the junction of internal jugular and the subclavian vein, or the brachiocephalic vein, left brachiocephalic vein. Other veins which might be injured at the lower end of the thoracic cavity includes esophagus vein, and inferior vena caval damage can also happen with thoracic surgery. These are all systemic veins which are involved. Now coming to the pulmonary circulation, your right pulmonary artery, left pulmonary artery or the main pulmonary artery and the pulmonary veins also might be damaged, which can lead to dangerous hemorrhage. Other thing which can be involved includes pericardiophrenac artery and vein. Now coming to one more complication, that is respiratory failure. It is the leading cause of postoperative morbidity and mortality. What is this acute respiratory failure? Acute onset of hypoxia. Your PaO2 is less than 60 millimeter of mercury. Next is acute onset of hypercapnia. Your carbon dioxide level is greater than 45 millimeter of mercury and you are using postoperative mechanical ventilation for more than 1 day. You are not able to wean the patient. And fourth criteria is you are re-intubating for controlled ventilation after extubation. After extubation, you are not able to maintain the saturation and you are re-intubating the patient after extubation. These are all few important criteria for acute respiratory failure. And the incidence of acute respiratory failure following thoracic surgery is between 2 to 18%, and the patient who are really prone for this respiratory failure are patients with decreased respiratory preserve in the preoperative period. Other factors which can aggravate this respiratory failure includes elderly population, presence of associated coronary artery disease, And the third important factor is amount of lung resection which you are going to do intraoperatively. This all can affect the respiratory function in the postoperative period. Coming to the etiology, the patient might be on mechanical ventilation which can lead to nosocomial pneumonia, or you give lot of positive pressure, you add lot of positive pressure and lot of PEEP which can lead to bronchopleural fistula. And you are doing a surgery, and this suture lines, when you give high pressure, this suture line can give way and lead to fistula. So you have to minimize the positive pressure as much as possible in thoracic surgery. And this bronchopleural fistula as well as nosocomial pneumonia can lead to postoperative failure. Another important thing is in the intraoperative period, you are not able to isolate the lung properly. What happens is there can happen a cross contamination from the diseased lung to the normal lung because your lungs are not isolated properly. So the disease process from the operative lung can go into the non-operative lung, and this can lead to pneumonia of the normal lung, which leads to postoperative respiratory failure. So in the intraoperative period, one lung is collapsed and another lung you are going to ventilate, and how it can lead to acute lung injury. Positive pressure ventilation from the lung, ventilator associated lung injury. Your pulmonary capillaries on the ventilator lung is very high and your volume management is very important, and there is going to be increased capillary hydrostatic pressure, and any volume or any positive pressure if you are going to give, it is going to lead to injury of that particular lung. And free radical production from the ventilated lung and ischemia reperfusion from the non-ventilated lung. Finally, the release of pro-inflammatory mediator due to stress of surgery can cause acute lung injury, which leads to respiratory failure. So how you are going to manage it? First and foremost is use of thoracic epidural analgesia during the perioperative period. And by giving good analgesia, you decrease the pulmonary complication, particularly in high-risk patient. How does giving thoracic epidural analgesia help to reduce the pulmonary complication? First is it prevents the atecletasis and also reduces the secondary infection. It gives a better preservation of functional residual volume, and it also provides efficient mucociliary clearance, and it also alleviates the inhibiting reflex acting on the diaphragm. So there are various mechanisms by which thoracic epidural analgesia helps in preventing the pulmonary complication. Other things which can help to prevent this respiratory complication includes early extubation, good chest physiotherapy, incentive spirometry, and early ambulation. Supportive therapy to improve the oxygenation, to treat infection and provide vital organ support, but all this should be done without further damaging the lung. Now coming to the another important complication which is having high mortality, that is cardiac herniation. As I said earlier, it is rare but well described complication following pneumonectomy. This complication occurs when the pericardium is not completely closed or the closed pericardium breaks open due to pressure effects. It occurs immediately or within 24 hours after surgery. It is associated with greater than 50% mortality. The mortality is really high with cardiac herniation. It can happen, this cardiac herniation can also happen after lobar resection with pericardial opening, chest wall resection involving pericardium. Here it is going to be a lot of resection, and this can lead to cardiac herniation and traumatic cardiac herniation. Here you can see the right lung being removed. Now you have done a right pneumonectomy, and once you give pressure, there is a slight herniation towards the right. Similarly, when you do a left pneumonectomy, now I am going to remove the left side. Left pneumonectomy is done, and the positive pressure which you give on the right side cause little herniation of the heart to the left side. So you have to understand, you are creating a vacuum on that particular thorax, and herniation can happen So you have to adjust the pressure in the other lung carefully. What happens after right pneumonectomy? You have done the right pneumonectomy. You have removed the right lung. There is going to be impairment of venous return of the heart with increase in central venous pressure. Your venous pressure will go up. There can be tachycardia, profound hypotension due to herniation. The patient might be in cardiogenic shock, and superior right side, acute superior vena cava syndrome due to torsion of the heart. These are the various things which can happen after right pneumonectomy. Coming to cardiac herniation of after left pneumonectomy, you remove the left heart. Here the heart is on the left side, so there is little less cardiac rotation. However, the edge of the pericardium might compress the myocardium, leading to myocardial ischemia, arrhythmia and ventricular outflow tract obstruction. This specifically can happen after left pneumonectomy. So, cardiac herniation occurs after chest closure because of the pressure difference between the two thorax. Both sides were equal and you removed one lung, so there is going to be some high or low pressure between the two thoracic cavity. This pressure difference result in heart being excluded through the pericardium. That is nothing but the cardiac herniation. The differential diagnosis for cardiac herniation includes massive intrathoracic hemorrhage, pulmonary embolism and mediastinal shift from improper chest drain management. These all three things can behave similarly to cardiac herniation. Now coming to management, it is an absolutely dire emergency surgery. Here you have to go for early diagnosis and immediate surgical management. Here you can't be conservative, you have to take up the patient for surgery immediately, and you have to relocate the heart to normal anatomic position. And the third thing which you do is you have to repair the pericardial defect or use of analogs or prosthetic patch to closure the pericardial defect so the heart doesn't herniate. And when you do this surgery, it is a redo. Okay, herniation has happened after thoracic surgery, so it is basically a redo exploration. Here you have to have a large bore IV access for infusing volume. The patient could have lost lot of volume and you need a large intravenous access, arterial line for invasive monitoring. And another important thing which you should do is to minimize the cardiovascular effect. You have to do certain maneuvers to minimize the cardiovascular effect. One is putting the patient on the full lateral position with the operated side up. So the herniation is not much. And in case of re-exploration, there won't be time to isolate the lung, and usually single lumen tube is preferred because here the time is very crucial. You have to take up the patient for surgery as soon as possible. And to maintain the circulation, you need vasopressor and inotrope. And another important thing in the intraoperative period in cardiac herniation is transesophageal echocardiogram. Here, after resuscitation and placing the heart back into normal position, you need echocardiogram to assess the function and whether heart is in proper position or not, and also to prevent excessive compression of the heart by the repair. Whether any lot of stress on the heart is there, you need transesophageal echocardiogram. And patients are usually shifted to intensive care unit post-operatively for elective post-operative ventilation. Here you should not try to wean the patient. Try to avoid complications in the post-operative period and go for enhanced recovery, particularly with thoracic surgery. Thank you.